Ladies and gentlemen, we appreciate you taking a little bit of your evening to discuss some data that maybe you have heard about, or maybe it is new to you regarding relapsed refractory renal cell carcinoma, specifically focusing on FOTIVDA, also known as tivozanib. My name is Angela Shakespeare. I am Regional Director of Marketing for AVEO Oncology, an LG Chem company, and it gives me great honor to introduce your speaker this evening. Your speaker this evening is Dr. Hardeep Phul. He is the Director of Medical Oncology and Infusion Program at Palomar Health Medical Foundation. He is also the Chief Medical Officer at Palomar Health Medical Group. He's a Specialty Director of Alumni Relations for Cleveland Clinic, where he did his medical school. He's a clinical instructor at UCSD. I think you all know what that is, but it's University of California, San Diego, where he also did his fellowship. Dr. Phul is not only the titles in which we just provided, but he's an incredible clinician. He cares about the patient, he looks at the patient, and he is someone that you would want in the room if your family member was diagnosed with cancer. And I am indeed grateful to also call him friend. Dr. Phul, I turn it over to you.
Thank you, Angela. It's very kind of you. I'm happy to do this talk for MOASC, and I'm so happy all of you were able to attend. I want this to be fun. I want everyone to learn, to feel free to answer questions or ask questions. The slides are the slides, of course, and we recently had a meeting where we had a wonderful stage discussion and talked about experience and the data, and I'm happy to do that. So if anyone has questions during this, please feel free to interrupt. I don't know if there's a function to raise your hand or ask a question in the chat box. Anyone feel free to interrupt me between slides, because my job is not just to present the slides. I want to have a great discussion and give you some knowledge on renal cell cancer and FOTIVDA. So without further delay, as you know, this is a slide deck about tivozanib or FOTIVDA. We'll look at the efficacy, safety, and utility of this drug, and we'll look at how it's approved in all our adult patients with refractory relapsed kidney cancer following 2 or more systemic therapies. So we'll talk about what that means. So as you know, this is a promotional activity by AVEO Oncology, a division of AVEO, and I'm a paid speaker. And so all of these slides are approved by the FDA. And so I will stick to slides. The contents of this talk is basically to talk about the challenges in kidney cancer, especially renal cell carcinoma, especially relapse refractory cancer, which we have in our clinics and the patients we see in the real world. We'll talk about tivozanib or FOTIVDA. I'll kind of go back and forth on these drugs so you get a hold for both names. The mechanism of action and how it's unique. Then we'll talk about TIVO-3, the study in which this was all approved, and how the landmark data in that study, including efficacy, and then tolerability, safety, information, dosing, tons of resources, and a summary of things, and hopefully a discussion either at the end or throughout if anyone has questions. So this is a very good slide to start. And when I do a speaker program in person, it's always so fun to go around the room and say, where were you when this happened? In this day and age, we're lucky. We have options. We have multiple lines of treatment. And as you see, the slide title says, how do you manage these people after 2 prior systemic therapies? There was a time in which we didn't have a luxury of saying even 1 prior or 2, 2 prior seemed like a luxury to get to. So it's really wonderful how recent improvements in medications and diagnosis and of course, recognition of symptoms have led to many more metastatic renal cell carcinoma patients going on to next lines of therapy, including 3rd, 4th, 5th line. They tend to get more refractory disease. They tend to already have been exposed to checkpoint inhibitors. That's what CPIs would be, or prior TKIs. And so as you get to that phase of treatment, you have to think, what was this patient's treatment journey? What were they exposed to? And what will be effective? It's interesting, even in this day and age, if you look at the data of all comers, only about half of these patients are going to make it to 3rd line treatment after getting 2nd line treatment. So still a very underserved area, and one for which there's a lot of opportunity. And of course, we know limited data are really available in such a space to know How do we inform our treatment sequencing for these patients, especially the highly refractory ones? And how do we also balance this with the fact that many of our patients at this stage, even if they're good or not good candidates, they may decline therapy. They may not be ready. They may have had bad experience with their existing treatment. So we have to balance risks and benefits, quality of life. So, this box asks, is this something you see in your later line relapsed refractory patients? I think most people on this call, especially our clinicians, will say, yeah, these are kind of the real world problems we have. And so it's wonderful to have drugs and trials that reflect the real world, something that we would all see in our clinics. So to introduce Fotivda or tivozanib, I want to first say, what's the FDA indication? It is approved for adult patients with relapsed refractory renal cell carcinoma following 2 or more systemic therapies. Notice that lingo does not necessarily mean systemic lines, but just 2 or more therapies. We'll talk about the trial in which it was approved and what the most common setting was, however, in which this was tested. What about the mechanism of action? Most people have seen various TKIs come to market. Most of them do very similar things. As we know, kidney cancer is a very angiogenic vascular cancer, especially clear cell histology. So anti-angiogenesis has always been a main function, a main target to control tumor growth and disease progression. What's unique about Fotivda, and this medicine we're talking about, is it's selective and potent to the VEGFR 1, 2, and 3 receptors. So it's an inhibitor of these receptors, very long half-life as well, over about 100 hours. So selectivity, potency, on-target effect, and long effect. In models of human renal cell carcinoma, Fotivda was shown to do what it says on this beautiful picture, basically reduce angiogenesis, permeability in the vasculature, and tumor growth ultimately. Any questions thus far, by the way? I know I've talked a lot. Any questions or pauses? Anyone in the chat box said anything so far?
Nothing in the chat box right now.
Okay, I will go forward. Don't be shy, by the way, please, as we're going, feel free to chime in. So we'll go right into TiVo-3, the randomized trial in which this drug is approved. So it's important to realize, imagine in such a space to do a high quality trial, a relapsed refractory patient who's seen very effective therapies, often checkpoint inhibitors, often TKIs. How do you design a study that's prospective, phase 3, high quality, to make good clinical decisions and conclusions? So TiVo-3 was that. It was the first, and it's the only prospective phase 3 study in this setting. So they took relapsed refractory renal cell carcinoma patients who have failed 2 or 3 systemic treatments. They looked at stratification of multiple different types of treatment, whether it was TKI checkpoint inhibitors, 2 TKIs, other drugs, including our mTOR inhibitors. They looked at prognostic scores for IMDC. And they randomized patients to the standard dose, which is 1.34 milligrams daily. It's 3 weeks on, 1 week off, versus sorafenib, 400 twice a day, which was the comparator at the time this trial was enrolling. And the idea was to treat until progression or toxicity. And some of the endpoints included PFS and secondary endpoints like response rates, duration of response, tolerability, and safety. So just going through the baseline characteristics, this is a busy table, but what I want you to get out of this is that the real worldness of this. These are mostly elderly patients. You can see the average age are in their early 60s, mostly male, mostly Caucasian in this trial. There was mostly clear cell, over 90% clear cell components in the histology, but non-clear cell was allowed. So you can see about 5% or 1% with other, or a component, even if it's not perfectly clear cell. You can see a majority of these fell into intermediate or poor risk IMDC criteria, already telling you, and these are very high risk patients. And a majority of them, as you can see, had at least 2 prior treatments. Almost 40% had 3 prior treatments. And if you look at what kind of treatments those were, About almost half had 2 VEGFR TKIs. About a third almost, or 25 to 30% had checkpoint inhibitor and VEGFR TKI. And then another category of other plus TKI. We can talk about what that meant. Here's the incredible statistic. If I were to take one thing away from this graph and say the time from initial diagnosis to the time to this trial in both of these groups was 50 months. That's about 4 years. If I saw that alone and nothing else, I would say, wow, it's amazing what we're doing. We're getting better at kidney cancer. That wasn't the case in the early 2000s when I first started doing research in this area. 50 months to make it that far, and then to say we have some more treatment for you that'll still be tolerable and effective. It's a great thing to be able to say. So there's a common patient case. Let's say a patient that would be on a study like this, a real world case, something all of us could maybe see in our clinics. This is a 53-year-old male with stage 4 clear cell renal cell carcinoma. The sites of metastases are in the lung and adrenal gland. And the medical management was checkpoint inhibitor followed by VEGFR TKI. So this person has had 2 systemic treatments and has a history of coronary artery disease, adrenal insufficiency, hepatic cysts, fatigue, and arthralgias. So this patient has progressed on checkpoint inhibitor and VEGFR TKI, entering the third therapy, third line in this case, started on Fotivda after progression on these prior therapies. So what would be some clinical goals, for a challenging case like this? And you could say, what are the challenges in a case like this? Anyone want to venture a discussion, or either in the chat box or just chime in? Feel free to talk in. We have a shy audience. Is there any typing going on?
Nothing currently in the chat box tonight. We're a little quiet this
No problem.
evening.
I don't mean to put anyone on the spot. I would say we could look at the challenges of such a case. You could say this is a patient that's clearly progressed on effective treatments, has a lot of comorbidities, some of which they could be developing, tiredness and so forth, possibly reactions and side effects from their treatments. Entering third line, possibly have a risk of early relapse and symptoms and ongoing fatigue, ongoing intolerance, and so forth. So a very challenging patient to treat. And my goals in a patient for a patient like this would be to look at the treatment journey, see what they've experienced, see what I can offer that's effective, possibly different, and still safe, still keep them on therapy longer, hopefully reduce the intolerability that they may have experienced thus far. So TiVo-3, what about the study results? This is the main endpoint, PFS. And you can see a significant improvement in PFS, 5.6 months versus 3.9 months on sorafenib. But if you look at the 1 year, progression-free interval, it's about 28% of patients with Fotivda versus 11 on sorafenib. And if you look at 2 years, 18% versus only 5%. So to even have data at 2 years, and we'll talk about even more extended data than this, is pretty powerful in a patient who's been heavily pretreated, such as the patient in this trial, some of them entering basically their 4th medication they've already had. Very real world population, a very difficult, very stringent endpoint, PFS. So I alluded to this. What about the long-term PFS? Can you have 5-year follow-up in a kidney cancer patient who's on 3rd or 4th line sometimes? Well, yes, you can. And look at this landmark analysis. This was just very recently published and shown. Fotivda is 12.3% at 3 years, 7.6% at 4 years, 0% with sorafenib. So we look at this and say, well, 7.6%, what does that mean? I mean, that's low. That's quite outstanding at 4 years to have PFS on a single agent tablet after significant progression on prior treatments. So still very good data showing a very stringent outcome out to 4 years. We also looked at PFS responses based on prior treatments. Remember, these are not powered necessarily, including the long-term PFS. They were not powered for subgroup analyses, but you'll see interesting trends. When patients had prior VEGFR TKI and checkpoint inhibitor, you can clearly see the hazard ratio favored Fotivda versus sorafenib. And they had 2 prior VEGFR TKIs. Again, a very favorable hazard ratio. These are about 40% reduction or improvement in PFS. The only prior treatment, which was a very heterogeneous group, was VEGFR TKI and other, which include things like interleukins and things like mTOR inhibitors, a very heterogeneous group. It did not meet that, let's say, that significant or just any change really with a hazard ratio of 0.98. So again, not powered for these subgroups, but definitely very powerful trends in common patients treated with common regimens. This is what I really hone in: durability, response rates. Many of you heard me speak and talk to patients, and my number one thing is journey, duration, marathon, not a sprint, right? We're lucky in this day and age to have such a luxury to say we have time we can keep you on therapy, we have options. To be able to tell one of my patients that at 12 months, 71% of you responders will still be responding, and the response rate overall is 18%, but the disease control rate, which includes stability of disease, is 73%, and the duration of response not reached in that analysis. That's very powerful. That tells me that I can keep patients on treatment longer, and even if I do not get a complete response or a stringent response, in my practice, if I can keep durability, length of treatment, safety, efficacy, and keep things stable, that is a very powerful outcome in a heavily pretreated patient. Many of you will see this other outcome listed here, the overall survival. Remember, this was not a primary outcome of the study. They did not meet the overall survival outcome. So follow up on this case, this theoretical yet actually very interesting case, very similar to one that I had recently. You can see for this patient, this is a good candidate for doing basically third line or the third treatment with Fotivda, because this person has prior checkpoint inhibitor therapy and prior VEGFR TKI. We'll talk about how adverse events can also be managed in this population, including heavily pretreated patients with toxicities that they may pick up along the way. So again, questions, usually really fun to do in person or on stage, but what are your thoughts on this data, especially efficacy? And are they in line with what you would expect given the population? And what are the common things that come up on, when on these discussions? It's, well, that's pretty amazing that you have that efficacy in such a heavily pretreated population and the duration of response. What about the safety? What are the patient's side effects having been heavily pretreated? So we often talk about that on the next slides. And are these in line with what you expect in such a population? Honestly, when I first saw this data, I would say no, I did not expect it to be that effective in a patient who was heavily pretreated. And I would also say, well, what is the safety? Where is the compromise? How are you keeping them on treatment long enough to get a response?
Dr. Full, we
Yes.
do have a question in the
Wonderful.
chat. They ask, do you agree with clinical trials, or I'm sorry, do you agree that clinical trials should be considered first over this drug?
In my experience, of course, I've done an academic career before this, and I strongly believe in research. In my practice, I tell every patient, we're always looking for new knowledge and new information. This is how we get new late-breaking drugs such as Fotivda. This would not have happened without a trial occurring in the past. As we do more and more trials and we get data and information and more lines of treatment, what I'm finding in the community is that more and more patients have options. For example, first and second line in renal cell cancer, at least in our community setting here in Southern California, I feel many doctors know their options, have a lot of effective options that are NCCN approved. And now in third line with this drug and other medications and combinations available, you could say many patients still have very effective options available. So is it wrong to refer to clinical trials or second opinion or academic centers? Never. At any point in the journey, I enable my patients in my practice to have knowledge. I say knowledge is power. If there's something new happening at a competing institution, I don't like to use that word competing, but another institution, I'm all for it. Get a second opinion. Know what's happening there in case you want to plug in there in the future if third line or fourth line doesn't work out. So my overall answer is it is not wrong to refer to clinical trials at any time. That is how we get better as scientists, as physicians. That's how we find new medications. I'd like to say in a patient like this, a real patient, actually somewhat similar to one that I've treated recently, FOTIVDA is a wonderful choice, a very good choice that's effective and can buy some time before we're running out of, let's say, options and need to use clinical trials, let's say. Does that answer that question? Anyone else have any comments? Okay, I'll assume I'll move on. Feel free to keep chatting in the chat box. I can't see it, by the way, so let me know. So I alluded to this, much of what in these programs, when I speak and you see the data, you say, great, now what are you compromising? Are these patients really tolerating this? We've heard of TKIs, there's so many out in the market. What is different and what is the real tolerability, especially in this trial and in your experience? So this is a interesting plot with different colors and we'll walk through it, but the right side, think of as sorafenib, the gray side, the blue side, the left side is FOTIVDA. And obviously the bars, as they lean towards one direction or another, that means the percentage of patients with certain side effects. If you just look at the overall slide and say, okay, what are the things that are common? You can see in almost every TKI or oral therapy for kidney cancer, you have side effects like fatigue, high blood pressure, bleeding, diarrhea, and nausea and vomiting. Very common across both of these drugs. If you look at the ones that are more common, leaning toward, let's say, one side, and that would be FOTIVDA, it'd probably be fatigue and asthenia, which was a combined endpoint, by the way, which is why it appears as a little higher than you expect, 67%. Hypertension, common in TKIs, some diarrhea, nausea, and vomiting, the most common. Now, if you tease out, those are all grade toxicity. These darker bars teases out grades 3 and 4. And when you see a circle with an orange number in between, it means there's a greater than 5% difference between the study arms. So if you look at it this way, you could say really the only main grade 3 or 4 ones that are going to strongly affect patients and cause problems are fatigue and asthenia and high blood pressure. And of those, only one that's significantly higher than the comparator sorafenib is hypertension. Nearly everything else, including diarrhea, rash, and PPE, I didn't mention PPE earlier, but these kind of hand, foot rashes and syndromes, a lot of our patients get on TKI therapies. These are much higher on sorafenib. There's also a whole multitude of possible blood and laboratory abnormalities. You can see them listed, but essentially the ones that were more than 5% were hyponatremia, increased lipase, decreased phosphate, decreased lymphocytes. In all of these patients, I'm usually in my practice monitoring blood counts, metabolic panels, and urine protein, and we'll get into that. With that said, you could say, how safe is it really? Can you tell by how patients experience it and dose reductions and interruptions? Well, yes, if you look at that data, and again, the blue bars being FOTIVDA, you can see in all of those categories, there is a significant decrease in the amount of interruption, reduction, or discontinuation. For a majority of patients, the patient time on FOTIVDA, greater than 31% have greater than 1 year. So when you have a safe drug and you know how to manage the toxicity, you have different dosing forms, which we'll talk about, you can anticipate, right, what could go wrong. The whole idea, a lot of my patients, they'll come in with the FDA insert of any drug or the label, and it'll say a whole host of things, and it'll scare the patient. And I tell them, well, what is the percentage of that happening? And when you know something's going to happen, how can we anticipate it? And knowledge is power. If you know, for example, there's a risk of high blood pressure, we better be watching high blood pressure. If there's a risk of rashes, please report those so we can treat them early. Same with diarrhea, same with any of these other side effects. So in my practice, I'm huge on education, telling people, again, it is not a weakness to know that there's side effects possible. That is power. We need to anticipate such things. And one of the biggest things we don't do in practice is empower our patients to recognize them and tell us so that we can make an impact and change the journey before we discontinue, let's say, an effective drug. So going to the next one, this is another hypothetical patient profile. This is a 61-year-old with stage 4 clear cell renal cell carcinoma, treated with checkpoint inhibitor and TKI combo, followed by VEGFR TKI. This is really the current, let's say 2023, probably the most common patient scenario, one in which they're heavily pretreated, 3 prior drugs, entering though third line, so to speak. This patient has lung and liver mets, has high blood pressure, diabetes, and neuropathy, was treated with pembroexitinib for 15 months, had adverse events, managed with supportive medicines, but discontinued due to liver mets. And the second line was cabozantinib, very common second line NCCN approved option. Treated now for a decreased amount of time, as you expect throughout the treatment journey, this time 7 months, had some adverse events, required dose reductions, but discontinued eventually due to bony mets. So clearly this is a patient that's very advanced, has had very effective, but very potentially toxic therapy with side effects, heavily experienced now, refractory, you could say, to different mechanisms. So you look at the FOTIVDA data and you say, well, how would you manage this patient? And do you feel this matches up with that trial, the TiVo-3? Is this a patient on that trial, and how would their results in efficacy and safety tolerability be for such a patient? And I would argue that is a perfect patient. It's a real world one in which this trial was basically designed for, and there is efficacy and tolerability there. So some more important safety information, a lot of this is small print, but we do know in all of these TKIs, hypertension and crises with hypertension can be reported. We saw the hypertension data on those other graphs, but hypertensive crises, about 0.8% of patients. We should definitely monitor for any uncontrolled hypertension, keep patient on medications when needed, and alter them and titrate them as needed. If we cannot control it, we should discontinue FOTIVDA and other TKIs. As far as cardiac failures, 1.6% in FOTIVDA treated patients, of which 0.6% were fatal. Again, going with the cardiovascular system, you must monitor these symptoms, you must recognize them and dose interrupt or reduce or discontinue when appropriate. Same with cardioembolic events or arterial thromboembolic events. Again, not very high, about 3.2% had cardiac ischemic events, of which 0.4% were fatal, and arterial thromboembolic was 2% and 0.1% fatal. So a lot of these patients, if they're elderly, they have cardiovascular comorbidities, if they're on blood thinners, if they're at risk of stroke, heart attacks, certainly have to monitor these patients closely. And if they have a very serious adverse event, to consider discontinuation. Same thing with venous thrombotic events. This can happen, any sort of thrombosis. About 0.3% were fatal in this study. So we have to watch patients who are at risk. Hemorrhagic events, again, one of the risks of TKIs, especially VEGFR receptor blockers, is bleeding. This can happen in this trial, 11% of patients, only 0.2% were fatal. So watch for that. Proteinuria, very common in this treatment class, happen in 8% of patients, only 2% were grade 3. I often ask the audience here, when you get moderate to severe proteinuria, how are you monitoring it and altering it? But basically, the key is, do you monitor? Do you get a serial UA, watch for protein, and reduce the dose and interrupt it when needed? Thyroid dysfunction can also occur, again, 0.3% were grade 3. I do monitor TSH and sometimes T4 in my practice for patients on this. Wound healing complications, again, going in with the class of medication. You should hold this medicine at least 24 days prior to surgery, and afterwards about 2 weeks, or at least adequate wound healing. RPLS, a theoretical risk that can occur, evaluated for any patient with any strange headaches, visual disturbances, confusion, altered mental status. And embryo fetal toxicity, fortunately, I have not had a situation like this, but this can potentially cause fetal harm. So important for any females who could get pregnant or anyone who's married to someone who could get them pregnant to use effective contraception. Lastly, one thing that they want you to know is the lower dose actually has a yellow dye called tartrazine, which can cause allergic reactions in patients who have bronchial asthma, especially. So I've not come across that, but just something to remember on any patients, especially if they say they have a lot of allergies or asthma. We talked about a lot of these other adverse reactions already. I didn't say it's a strong CYP3A4 inducer, so you have to think about it. It's really important to involve pharmacists and other members of the care team to look for other interactions. We didn't talk about lactation, but this could theoretically get into breast milk, so advise women not to breastfeed. And there is no dose for renal impairment, though for moderate hepatic impairment, you can reduce the dose. As far as dosing, or actually I'll pause. Any questions on toxicity? I know that was a lot of small print and slides on safety. If not, I'll move forward with dosing. It's really quite simple. It's 2 doses, the maximal dose, 1.34 milligrams, and the altered dose reduction. There's only one, 0.89 milligrams. It's 1 capsule with water, with or without food, 3 weeks on, 1 week off. In my practice, patients love having a week off because it means they can feel normal if they had toxicities, or even if they didn't, the idea that they get a week off every month. It's empowering for a lot of patients, especially if there's a holiday, and it can be timed as such. It's really nice to have that built in. And part of that's the pharmacokinetics and the long half-life. So 28-day cycle, a monthly cycle. I often see these patients about once a month, corresponding to the cycle. So that's the dosing, pretty much very simple dosing. So to summarize, what you've seen today, I hope, is that FOTIVDA demonstrated longer PFS, improved tolerability as well with that PFS, and it's the first and only large prospective, well-designed trial in such a relapse refractory population. Real-world patients getting 2 or more systemic therapies, including checkpoints, including TKI, and everything in between, heavily pretreated. You see the PFS is improved. You see the landmark PFS at 1, 2, 3, and 4 years is higher than the comparator. And you see a long duration of response with disease control rates and overall response rates being higher than the comparator with sorafenib. And again, though it was not powered in all the major subgroups, at least the most common subgroups we see in the modern era, which is mostly checkpoint inhibitors and VEGFR TKI or 2 VEGFR TKIs, there's a strong trend and correlation towards a major improvement by almost 40% in PFS. Again, exploratory, but a very interesting trend. You can see the most common adverse events, what we expect sort of on TKIs, such as fatigue, high blood pressure, diarrhea, decreased appetite, nausea, and you can read the others. And really the ones that were greater than 5% in grade 3 or 4, the ones you really worry about were basically the things like hypertension, fatigue, and decreased appetite. But with all of that said, it is wonderful to see a drug that's effective and tolerable such that patients on it have fewer dose reductions, interruptions, and discontinuations compared to comparing to sorafenib in this case. And again, it's a very simple medicine to take. Patients love to have the week off. It's a very simple 4-week cycle, and there's 1 dose reduction possible to help patients who are struggling. And there's obviously a lot of great resources. Usually I call on the rep in the room when we're having an in-speaker program, but there's a wonderful experience program for FOTIVDA and AVEO ACE program. These give samples to get people a head start on treatment. They offer personalized coverage and support and copay for people who are underinsured or uninsured. And I've used this program and it is fantastic. And they are actually responsive when you call this phone number. So if you have a local AVEO representative or oncology account manager, please reach out to them if you have a new patient. It will help you get started early, as it did for my patients. So that's really the end of these slides. I didn't want to make this too slide heavy, but I wanted you to see the data. I definitely welcome more chats, discussions. Feel free to chime in. We have plenty of time to talk more.
So we have one from Amy Yim. Hi, Dr. Full. How do you know when a patient is ready to start FOTIVDA? I am sorry if I missed this discussion.
Thanks to Amy. Amy is an outstanding pharmacist that I know and an incredible partner. I hope you got to get to those slides, Amy, where we talked about how great pharmacists are in helping us with all these medications. You know, oncology cannot do it without an incredible pharmacy team. But yeah, the first few slides I think you missed. You joined a little bit after that when I saw you come up. But how do you know when they're ready to start? I mean, you look at what it's approved for, FDA indication. It's approved for patients with 2 or more systemic therapies. You look at the treatment journey and what the patient has had. In this TiVo-3 trial, patients have had usually some form of checkpoint inhibitor or TKI, whether it's 2 TKIs or checkpoint inhibitor plus TKI. It's often a patient entering what you would consider third line of treatment. But if you, depending on what you call a line, if they've had 2 or prior systemic therapies up front, could you use it in second line? I mean, there's a possibility. If you looked at I don't think you saw, Amy, the first clinical trial design and the baseline characteristics and where the patients were in therapy. And if you saw that slide, it was mostly patients entering 3rd and 4th therapies, essentially, or very advanced patients, probably more often than not 3rd line. So this drug at this time is most, I would say, aptly suited for that sort of situation. A very real world position in which we find ourselves as a single agent, let's say, after prior failure of treatment. I hope that answers your question.